Okay, Assalamualaikum warahmatullahi wabarakatuh. Good morning, Farhana.
Yes, Rob.
How are you doing today?
Alhamdulillah, doing well.
Alright, okay, good. I found that you have selected one case to present for our case-based discussion today. Alright, let's start with the case.
Okay. So this is a 47 years old lady, known case of breast carcinoma, diagnosed 2024. At that time, the clinical stage was T4B N2M0. She was previously positive for ER/PR and HER2. So underwent neoadjuvant chemotherapy and also post-chemo CT shows smaller size lesion lah. So I received a left breast mastectomy specimen weighing 250 gram, tagged with one short suture as superior and one long suture as lateral. That is measuring 165 times 150 and also 55 with presence of nipple bearing skin on the superficial aspect measuring 105, 90 and 5. There is a well-healed scar on the on the inner upper quadrant measuring 20 times 10 mm. So the deep margin of the tissue is composed of fatty tissue with one foci of muscle. And upon palpation, there is a firm to hard mass on the upper outer quadrant, which correlate with the radiological imaging of the previous tumor size. So on cut section, there is a presence of whitish lesion measuring 40, 30, 15 with the distance of the lesion to the margin is as follow: 75 to superior, 20 to inferior, medial 25, lateral 110, and less than 1 mm to the superficial, and deep 14 mm. Also, upon serial cut section, there's another fibrotic tissue on the outer upper quadrant, measuring 15 times 10, and the second lesion is 10 mm from the first lesion lah. So I submitted the breast tissue as follow: superior margin, inferior margin, medial, lateral, with the nearest superficial and deep, and also the representative section from the lesion and the second lesion, also the nipple areola complex. So otherwise, on the axillary retain, there is no lymph node identified, but the specimen is also sent with another specimen, which is the axillary lymph node. So I identified 9 lymph node lah on the axillary lymph node specimen, where measuring 3 to 10 mm, which is all submitted. So on microscopy, so this is a breast specimen, so showing viable malignant cell. The cell is within the fibrotic stoma. So the malignant cells are arranged as we can see in cords and single nest with minimal tubule formation. For this one, I score as 3. And then the cell exhibit moderately promorphic nuclei with prominent nucleoli and moderate amount of cytoplasm. Mitosis, I already count, is 3 in 10 high power field, which correspond to the score 1 lah, Bruno resection. So the malignant cell is seen infiltrating into the muscle layer and also the overlying epidermis. Otherwise, no DCIS or Paget disease of the nipple appreciated lah. So of the 5 D nodes, all are positive for tumor infiltration.
Alright, from that microscopic findings, so what your interpretation for this case?
Okay, for this case, I conclude as it's an invasive breast carcinoma, no special type. So for the staging, the YPT2, because the tumor size is 4 mm, and also for the Miller-Payne grading, because I think it's about 30% viable tumor, so I score as 2 lah. So axillary lymph node is positive, so N1.
Alright. Okay, before I proceed with another question, I think, thank you for picking up this case. I know that, I think you know that post-neoadjuvant chemotherapy specimen is quite challenging for us to evaluate. First of all, I would like to ask, do you know what do you think this case? Why they proceed with neoadjuvant chemotherapy before surgery?
Okay,
Yeah.
So based on my reading, usually in breast cancer patient, we proceed with neoadjuvant chemotherapy to reduce the tumor size and also tackle if there is other regional metastasis. So when we reduce the tumor size, it is better for the mastectomy for the reconstructive surgery after that.
For reconstructive, reconstructive surgery.
Yeah.
Yeah, I think that one for early case, I think for early stage of disease. But in this case, they proceed with they proceed with mastectomy. Is it possible with the post neoadjuvant chemotherapy they can avoid mastectomy?
Usually, the management is mastectomy to remove the tumor. Unless post chemo, there is no residual tumor noted.
Yeah, so meaning that in certain case they can avoid mastectomy because the tumor already reduced and maybe a complete response to chemotherapy. They can just do it, the breast conserving therapy, for example. All right. Okay. What is actually the pathologist's role in the evaluation of the response to neoadjuvant chemotherapy?
So our role is to aid the clinician in assessing the pathological response to the chemotherapy, because when we examine and also submitting the specimen, we can assess the tumor response to the chemo by using the Miller-Payne regression staging.
How many types of the tumor response? How many types? Meaning that why is there any possible for tumor to completely respond, or what we call it for the not completely response?
May I rephrase? Do you mean
if complete response, what we call that?
Complete pathological
pathological response.
No.
Pathologic complete response, PCR.
Yes.
And when we have not complete, what we call that?
It's
maybe we have partial pathologic response.
Yeah,
but we translate that into our Miller-Payne grading. All right.
Okay.
So you said that this is a grade 2, right?
Yes.
Miller-Payne. What do you mean with that?
Because Miller-Payne grading is divided into 5 grades. Grade 1, there is no chemo regression therapy effect at all. Grade 2 is at least 30% regression. Grade 3, more than 30 up to 90. Grade 4, more than 90. And grade 5 is the complete pathological response.
All right. Okay, that's good. The most important in post neoadjuvant chemotherapy is to assess the tumor bed. Other than measuring the size, what else we need to assess the tumor bed?
Okay. The tumor bed, as Prof said, is the size and also the fibrotic area around the tissue that correlates with the previous pre-chemo area.
Yeah. So, meaning that the pathology appearance post chemotherapy, is it only fibrosis? I think we have many other changes that lead to the pathological changes in the pathologic appearance due to chemo. Do you know that?
Is it on gross specimen or microscopic?
Gross and as well as translated to microscopic.
Fibrosis
maybe in gross,
and then
microscopic.
Microscopic, we can see the fibrotic, and then the inflammation, histiocyte, and also the what's the name? The tumor cell necrosis.
Yeah, all right. Chronic inflammation, and sometimes they can have a histiocytic reaction. There's a lot of histiocytes in that place, right? So that, okay, do we need to assess that changes only in tumor bed, or is there any other area that we need to assess?
We need to focus on the tumor bed,
and
but
then
also the rest of the breast tissue.
the rest of breast tissue. What about the lymph node?
Yes, lymph node also.
Yeah. Okay. While examining the lymph node, do you assess all the changes, the chemo, the pathologic appearance post chemo changes in the lymph node?
In this case, yes.
Yeah. And then when you detect any changes, what you need to do?
What I need to do if I detect changes?
So you need to describe it.
Describe in
your description. All right.
Mm-hmm.
And then for the lymph nodes, apart from counting how many lymph nodes involved, okay, what else you need to examine for the lymph nodes?
Whether there's any capsular invasion.
Capsular invasion, or we call it extranodal
Extension.
extension.
Yeah.
Okay. So do you report that? Is that in our case? Is there any extranodal extension?
No, there's no extranodal, but sorry, there's no capsular invasion, but there is a tumor deposit.
Tumor deposit,
yes,
meaning that outside of the
lymph node.
the lymph node, right? So how we correlate that? Is it from the lymph nodes, or direct from the tumor deposit from the
tumor
main
deposit
tumor?
is usually through hematogenous spread.
Hematogenous
or
spread.
direct expansion.
All right. Okay. All right. What about DCIS? Do you see any DCIS in your case?
In the specimen that I have examined, there is no DCIS that
No,
I
at
noted.
all.
Yes.
Okay. If you have the DCIS, what should you do?
We need to grade and also report regarding the DCIS.
Grade DCIS. What do you mean with grade DCIS?
Is it low grade or high grade DCIS, and also the size and the distance of DCIS to the margin also.
All right. Okay. And then, do we need to assess the changes in DCIS post chemo changes? Is it possible for the DCIS to be vanish post chemo?
I will look through it again. I'm not sure regarding
So
that.
you're not sure about
Yes.
that, yeah? Any wisdom guess?
I think it will persist.
Persist.
But have changes also lah.
Yeah.
Because chemo target all all tissue, they're healthy and cancer cells.
Yeah. We cannot say it will be totally respond no DCIS from DCIS and no more DCIS. I think that's quite impossible. But what we need to do is to assess the cellular changes, the cell within DCIS. Maybe now it become like just like in the main tumor, maybe they will be replaced by the histiocytic reaction within the
DCIS
ductal component. Or the cell changes like can you please tell what the changes of the cell post chemo?
Chemo-related changes, the cell can have vacuolated cytoplasm, nucleomegaly, coarse chromatin, and also the degenerated lah, like necrotic.
All right. So
and
this is all.
Myoepithelial.
All right. This is all that the things that you need to describe in your report. So we know that there is some response to the chemotherapy with that changes. So we can assess the changes, the chemo response, right? Okay. What about the margins? Is there any? How to report the margin? Is it similar? The mastectomy specimen with the post neoadjuvant?
Principally, it's the same. We still measure the distance of the lesion to all the margins and reported the closest margin and whether it is involved by the tumor.
All right. Okay, what about the residual cancer burden post NAC? Do you aware about that? What are the things that you need to see overall about the tumor residual cancer burden?
Residual cancer burden is the remaining tumor cells post chemo lah. So I think it's a numeric percentage grading also.
Percentage? What percentage?
Percentage of percentage of reduction of the tumor size.
Okay, one thing. But before that, of course, you measure the tumor bed, right?
Yes.
So the tumor bed dimension is part of the residual cancer burden, and then the overall residual tumor cellularity also in the form of percentage. All right, and then also if you have DCIS, you need to give the percentage for the residual tumor that represent themselves as DCIS. All right, and then the number of lymph node also indicate of residual cancer burden. So the number of lymph node here is 9, right?
Yes, I identified 9.
Identified 9. Do you think that enough?
It's supposed to be as many as possible, but the minimum is 10.
Yeah, and then one more thing is the largest diameter of the tumor metastatic focus. So in the do you measure the largest?
The largest is 10 mm.
10 mm within the
axillary lymph node.
lymph nodes. All right. Okay. Okay. Maybe one last question, because you not mentioned about the tumor marker. Yeah, I know that this case is ER/PR positive previously, right? And HER2 negative. Do you think that we need to repeat the tumor marker for the post chemotherapy?
Yes,
specimen?
we need to repeat because the tumor can have a different expression post chemo.
Different expression. So by right we need to repeat, right?
Yes.
So in this case, do you repeat?
I repeat the ER, which is negative in this patient.
ER?
Sorry, HER2.
HER2. I think you not repeat the ER/PR because already positive, right?
Yes.
That's good enough. But we repeat the HER2, but still negative, right? But when we give the positive or negative for HER2, we need to proceed with the scoring. I mean, what do you mean by negative here? Is it 0 or 0 plus or 1 plus?
Okay.
2 plus?
In this case, I think it's 0.
0.
0.
So no
expression,
membranous
expression at all.
Yes.
Yes.
Isn't it? Even a little expression which is less than 10%, you need to consider it. Maybe
if like there's a little,
maybe
we can
ultra
score
low
as 0 plus.
or something.
Yes.
Or 0 plus or 1 plus, maybe if it more than 10%.
Yes.
Is it? All right. Okay. And then what the thing that I think better we do for immunomarker, since this patient is ER/PR positive. So in a molecular subtyping, so it become what type? Luminal A or B?
Because ER/PR positive is luminal A. HER2
Negative.
also negative, so it's luminal
A.
B.
Luminal A.
Sorry.
This is luminal A.
Luminal A. Okay.
Okay. To confirm, is it really luminal A or is it luminal B? Yeah, we better proceed with that.
Ki-67.
So what about the Ki-67 in this case?
In this case, it's low. I count about 1%.
1% Ki-67. So what the significance of percentage of Ki-67? We take how many percent to consider
for
positive?
luminal A and B, it's luminal A less than 14, luminal B is more than 14 or any
14.
size.
You said 14. It's not 20.
Based on my unit is 14, but I will clarify back with you after this.
All right. Okay. Maybe we can take 20%. But of course, in this case, it's negative. So it's luminal A with a low risk. All right. Okay. That's good. Farhama, what do you think about this session? Can you please give your reflection? What have you learned from this?
From this session, so I think that I need to improve more on my grossing and description of the specimen, and I like that you clarify my understanding on the classification of the breast cancer.
All right.
For the improvement.
Do you think that we need to have a more discussion like this after this?
Yes.
Yeah. Right. You can select more case after this for our discussion. All right. I think you are good enough. You try your best. Just certain things that you're not sure. That's good. You need to go back and try to find out what is, because there is in breast cancer reporting, depends on your reference. Some reference they consider this and some not, but as long as you can justify that the important, you know what the important to examine that, that's very good. And basically you have covered everything, but I found that you lacking in your description. You not describe the tumor pathological assessment of the tumor changes post chemotherapy.
Okay.
Not that thorough. And regarding the lymph nodes, you not. I think
tumor response.
Yeah, the tumor response in the lymph node, for example, and give the percentage for DCIS or give percentage for the HER2. Not percentage, the scoring for the HER2. These are the things that you miss. And then for the tumor pathologic response, you need to describe well whether how their appearance. Sometimes the tumor become concentric. Sometimes the tumor become like what we call it. It become small or we call it scattered foci. Scattered foci, concentric shrinkage of the tumor, scattered foci. You need to mention that in your report. All right. So overall, you are very good. I think you can improve more after this.
Okay.
All right. Thank you.
Okay,
That's all
thank
for
you, Prof.
today's session.
Okay.